You're in a paper gown moment, waiting while someone wraps the cuff. Your feet dangle, your sleeve is bunched, and your arm has nowhere to go. That tiny detail can matter. In one Johns Hopkins trial, the wrong arm position pushed blood pressure high enough to change the category. Most of us treat the number like truth, but blood pressure is not just measured in your arteries, it's also measured in technique. In the 2024 ARMS randomized crossover trial, Johns Hopkins researchers studied 133 adults, ages 18 to 80, in Baltimore using automated upper arm measurements. A crossover design is helpful here because each person experiences every condition, so the comparison isn't just between people. It's within the same body. Researchers compared the recommended setup arm supported on a desk at heart level with two common shortcuts: arm resting in the lap and arm hanging unsupported. Softly. And the shortcut wasn't harmless noise. It moved the numbers in a direction that could make someone look sicker than they are. When the arm rested in the lap, systolic blood pressure averaged 3.9 millimeters Gui higher, and diastolic pressure averaged 4.0 millimeters Gui higher. When the arm hung unsupported at the side, systolic pressure averaged 6.5 millimeters Gui higher, while diastolic pressure averaged 4.4 millimeters Gui higher. That may sound small, but blood pressure categories are built on thresholds. A few points can turn, watch this, into "we need a plan." Johns Hopkins researcher Sherry Liu noted that 6.5 millimeters could mean the difference between 123 and 130, or between 193 and 140 systolic. That's not panic fuel. It's a reminder that the number deserves a fair test before it shapes your next decision. Johns Hopkins noted that nearly half of U.S. adults have elevated blood pressure, so repeated measurement bias can matter at population scale. High blood pressure is often silent. You don't feel a label appear. So the path to diagnosis usually starts with one ordinary cuff squeeze. The ARMS trial found similar overestimation patterns across subgroups including age, obesity status, hypertensive status, and recent access to health care. That consistency is the uncomfortable part. This wasn't only about one age group, one body size, or one unusually awkward room. This content is for informational purposes only and is not a substitute for professional medical advice. Always consult your doctor or a qualified healthcare provider before making changes to your health routine. So let's slow the scene down. The cuff tightens, your hand is in your lap, your shoulder subtly lifts, your muscles engage. Guidelines place the cuff at mid-heart level because gravity and unsupported muscle tension can change measured pressure, not just comfort. Your artery hasn't suddenly changed personality. The setup has changed the forces around the measurement, and the machine reports what it receives. Current clinical guidance emphasizes a fitted cuff, back support, feet flat, legs uncrossed, no talking, and an arm supported with the cuff at heart level. At home, consider building a little measurement ritual. Same chair, same table, same quiet pause before you press the button. Pause. Not a dramatic ritual, just boring consistency. Boring is exactly what you want when a number may guide medical conversations. Sit with your back supported. Put both feet flat. Let your legs stay uncrossed. Rest for 5 minutes if you can. Place your forearm on a table or firm cushion, so the cuff on your upper arm sits roughly at heart level. Consider checking that the cuff actually fits your arm circumference. A too small or too large cuff may distort readings too. Guidelines emphasize correct cuff size because an improperly fitted cuff can affect accuracy, especially for people whose arms fall outside standard sizes. Don't talk during the reading. Don't scroll, don't hold your breath. Let your hand rest open, like it has nothing to prove. The goal isn't to gain the number downward. The goal is to remove avoidable error, so the reading reflects you more accurately. The American College of Cardiology perspective said blood pressure measurement should be treated with the precision and seriousness of other medical tests. That line matters because we often treat blood pressure like a quick chore. Sleeve up, button pressed, result accepted, then everyone moves on. But a quick chore can become a medical label, and labels can lead to follow-ups, lifestyle plans, or medication conversations. If your clinic reading seems higher than expected, consider gently asking whether it can be repeated with your arm supported. You're not being difficult. You're asking for the recommended technique the same way you'd want a lab sample handled properly. In ARMs, participants were randomly assigned to sequences of arm positions, which helps reduce the chance that measurement order explains the findings. This is why the trial is stronger than a casual observation. It tested the positions systematically, not as an afterthought. Researchers used an automated device and repeated readings, then compared average pressures for lap and side positions against the desk-supported reference. So the takeaway isn't from one dramatic spike, it comes from averaged readings across people, positions, and repeated measurements together. If you track at home, consider taking 2 or 3 readings, a minute apart, then averaging them rather than reacting to one. Write the average somewhere you can share with your clinician. If writing stresses you out, ask what tracking method they prefer. And remember, one high reading does not automatically tell the whole story. Stress, caffeine, movement, pain, and timing may all matter. The RMS study used automated upper arm devices in adults from one metropolitan area, so results may not apply perfectly to every device or setting. That limitation doesn't erase the finding. It just keeps us honest about where the evidence is strongest and where we should stay curious. Because the same participants rotated through positions, the trial tested the effect of arm position directly. This was more than a simple correlation. Gentle laugh. It's almost unfair. You can eat more vegetables, walk after dinner, sleep better, and still get tripped up by an unsupported elbow. But that's also empowering. This is a fix that doesn't require willpower, expensive gear, or a perfect week. It requires setup. Try this before your next home reading. Chair pulled in, table close, forearm resting, palm relaxed, cuff snug on bare skin. If the cuff has to go over clothing, consider waiting until you can measure on bare skin, unless your clinician instructed otherwise. Guidelines commonly recommend placing the cuff on a bare upper arm and keeping the middle of the cuff near heart level. Keep the room calm if you can. Pets, conversation, cold air, and rushing can make the moment less consistent than it needs to be. If you find this useful, consider liking or subscribing. It helps more people catch small health details that can make care clearer. Now, let's talk about dignity. Asking for a repeat reading can feel awkward, especially when the appointment is moving fast. One sentence may help. You're trying to follow the recommended technique, and you'd like your arm supported at heart level. Most clinicians want accurate numbers too. A respectful question can turn a rushed moment into a better measurement for everyone. The ACC commentary argued that inaccurate measurement can lead to overdiagnosis, undertreatment, overtreatment, and unnecessary downstream healthcare activity later. That's the bigger story. Technique is not fussy perfectionism. It's part of protecting good decisions from bad inputs at the start. If your home numbers and clinic numbers disagree, consider bringing your device to an appointment and asking whether the technique matches. Professional guidance often relies on repeated measurements, not a single reading, because blood pressure varies from moment to moment in real life too. Think of it like weather, not climate. One gust matters less than the pattern you see under reliable conditions over time. If readings worry you, consider sharing the pattern with a healthcare professional rather than changing medication or supplements on your own. Here's the strange beauty of this study. The answer was hiding in a small gesture almost nobody thought much about. The RMS trial was published online in JAMA Internal Medicine in October 2024 and later appeared in the journal's December issue. Between those dates, the finding traveled fast because it touched something every primary care office and kitchen table recognizes immediately. Your next reading can be simple. Rest first, support the arm, keep the cuff at heart level, stay quiet, repeat. That's the whole move. Not glamorous, not complicated, just a better way to listen to a signal your body sends. ACC summarized that a side-hanging arm could raise systolic readings by about 6.5 mm G, enough to affect hypertension category for some people. So if a reading lands near a cutoff, consider whether technique was right before assuming your body crossed a line. This is not about ignoring high numbers. It's about confirming them carefully, because good care starts with good measurement first. If your numbers remain high with careful technique, that's a meaningful reason to consult your doctor and discuss next steps. Small skills add up. Reading a food label, walking after meals, sleeping on schedule, and now, supporting your arm correctly. The cuff may still squeeze. The number may still be higher than you hoped, but at least you'll know it got a fair chance. And that is a quieter kind of health power, not controlling every outcome, just improving the conditions for truth to show up. Next time the cuff tightens, let your arm rest where the evidence says it belongs, supported, steady, and level with your heart.